Hello, everyone, and thank you very much for finding the time to join us. I am very, very excited that you could join us on this edition of our first Facebook Live event presented to you by the 10,000 Family Study of the University of Minnesota. My name is Victor Ayara. On this edition, we would be talking about a very important aspect of our lives. We will be talking about the topic is actually over the hill. What hill? So today we're having a conversation about healthy aging. Wherever you're reaching us from, stay tuned. You're going to learn a lot. You're going to take a lot away from this interview session because the person I'll be speaking to is not just an expert, but he's an authority in the field of gerontology. Let me introduce my guest, but before I do that, I want to also let you know that, as usual, we have a gift card that somebody is going to win, and it is just based on participation and sticking around until the very end of this program. I would like to introduce my guest at this point. My guest is Dr. Joseph Gaugler. He is the Robert L. Kane Endowed Chair in Long-Term Care and Aging in the Division of Health Policy and Management of the School of Public Health at the University of Minnesota. He also directs the school's Center for Healthy Aging and Innovation. He does research on the sources and effectiveness of long-term care for persons with Alzheimer's disease and other chronic conditions. Dr. Gogler is a gerontologist and his interests include Alzheimer's disease and long-term care, the impacts of family care for persons with dementia and other chronic conditions, and the effectiveness of community-based and psychosocial services for older adults with dementia and their caregiving families. Dr. Gogler has served as an editor for several highly regarded academic journals and has received multiple awards for his work. Dr. Gogler's doctoral degree is in Human Development and Family Studies from Pennsylvania State University, and his bachelor's degree in Psychology and History is from Gustavus Adolphus College here in Minnesota. Thank you so much for finding the time, sir. You are a very busy man, and we are glad that you could join us.
No, thank you for the opportunity. I really appreciate it.
Thank you very much. And of course, just want to let you know that if you want to know more about Dr. Gogler and what he does, you can always find his biography on the university's website. And I'm not telling you to do that right now. You may be tempted to, but stick with us. Let's get the ball rolling and have this conversation. So I want to ask you, the first question I have for you today, sir, is what can you tell us about yourself, which I have not covered in your introduction?
Yeah, that's always the toughest question, isn't it? So, it is, I think, when we talk about this topic of aging, I always do reflect on my own experiences. I mean, we all have our own experiences with aging, whether it's ourselves or loved ones near us and otherwise. But I also like to reflect back on how I actually got interested in this in the first place. And so, like you said, I did my undergraduate degree here in Minnesota at Gustavus Adolphus College, a wonderful liberal arts college down in St. Peter, which is around an hour and 15 minutes, hour and 20 minutes south of the Twin Cities near Mankato. And while I was an undergraduate there, I was a psychology and history major. I wasn't quite sure where I wanted to go with those degrees. I knew I probably had to go to graduate school in some way, shape, or form. I just wasn't quite sure how or where. And one of the main emphases of Gustavus is on community and service learning. I think that's core to the philosophy of Gustavus, as well as many of the other small liberal arts colleges here in Minnesota. And So during my second year, I actually started volunteering. And one of the first places I volunteered at was at a senior living complex where I played cards with the residents, and I enjoyed that a lot. And then I followed that up with some other volunteer experiences, such as volunteering at the local nursing home and visiting and meeting with residents and such. And then at the end of my third year, I had a summer internship opportunity through my psychology degree or psychology program. And I actually did it at Catholic Charities in St. Paul. And so I was connected with the geriatric social work team there. And they would do home visits and other types of work, really kind of engaging with, conducting case management, following up with older people in the community, as well as caregivers too. And I remember very clearly the very first home visit we did was to a man living with dementia and his wife. And so I saw firsthand what that was like for them, what the experience was. And I think at that point, I really felt like I wanted to take particularly my psychology degree and focus it on aging, adult development and aging, and specifically within the dementia care context. And so after my prior to my fourth year at Gustavus, I actually did what was called the Undergraduate Research Opportunities Program, which is also and still is available and ongoing here on campus. But at the time, students outside of the University of Minnesota could apply. This was through the psychology program. And so I spent the summer actually doing research here at the University of Minnesota. And it was at that time I worked with a faculty member in psychology. Her name is Dr. Celia Gershenson. And she really was helpful to me in identifying what would be the pathways in graduate school after, that summer research opportunity. And that's what led me to going to Penn State, working with Dr. Steve Zaret, who's known as a pioneer in mental health and aging and dementia care. And, I think my career just really evolved from there.
Thank you so very much for giving us that glimpse into how you got here career-wise. And why is this? I know you mentioned that you actually lived with or worked with, had the first-hand experience of seeing what it is to take care of a loved one with dementia. Is that one of the reasons why you chose this line of work?
Yeah, I think that is definitely a reason why I chose it, Victor. I mean, I think too, and it's interesting how sometimes life works more in a circular way than linear way. Is when I started my academic career, I never really saw myself through the lens of a community engaged or community facing scholar per se. I mean, I was very focused on learning methodological techniques and skills and conducting data analyses and things like that, although it always was in the space of dementia care. But over time, and particularly when I was able to come back here at the University of Minnesota back in 2005, I started really kind of thinking about what is the kind of research I want to do and how can it best meet the needs of the people living with dementia as well as the people who help or care for them. And it really led me to start doing and really focusing a lot more on community engagement. Initially it began in somewhat of a self-serving way where I saw reaching out to the community and providing education and seminars and such as a way to identify people who participate in my studies. But it became evident very early on that, in fact, it was much more of an educational and core experience for me and my work that I do than it being kind of just a vehicle for research recruitment. So now, and based on what I would like to think is a fairly robust profile in community engagement, which is core to the work we do and many of our team members now, that I think that's really what drives me the most is when I hear and talk to families themselves, people living with dementia, not necessarily in the context of a research study, but when I'm engaged with them in whether it's, educational seminars or conferences we hold, et cetera, and hearing from them, what they're going through, seeing if the work we're doing is validated by them and that is what we're doing actually meaningful for them. Are there new paths or new directions we should be taking, new approaches, new techniques to, again, kind of better get our work and disseminate and implement our work so it has the widest possible impact?
Thank you so much. And I know that I actually attended one of your seminars, webinars rather. You have done a lot of such engagements before, my colleague would say, before COVID. You're actually going from county to county, engaging with families. Now, recently, I think that a lot of times people know that aging happens, right? But people don't really give it a thought, right? When I left high school, the first job I took was teaching very little children. And one of my recent trips to Texas, I met one of the children that I taught, and she introduced me to her husband and her little kids. And then I realized that I'm growing old.
Yeah.
So it just comes on us. Now, tell me, why is it important for us to pay attention to the aging process, and at what time should we begin to actually plan about, begin the process of taking, not just being cognizant of growing old, but beginning to put things in place for that process?
I mean, that's a gigantic question. I mean, one thing we know, and I think many would agree, whether those that are researchers, clinicians, people, just individuals, is aging. It's an individualized experience. It's also one that is very much a life course experience. And when I say life course, what I mean is when we think of a concept like healthy aging, and it means a lot of different things. I mean, and people and academics and theorists and others have attempted to just define and measure what is successful aging. But in the end, what I think it really is understanding our life course trajectory of health, and how throughout different points in the lifespan, whether they're transitional events or just general development, we have to understand how events early in the life course influence how we age. Because, I mean, again, when you think aging, you think old, whatever that means, or you might think of a certain chronological age. But in reality, I mean, so much of how we age, it's such a variegated, heterogeneous experience for each of us. And how we age is so much influenced by really our entire lifespan. So when considering aging itself, I think we have to and we must consider each of our histories in describing and explaining how we get to a certain point. I mean, the reason why lifespan is so much on my mind is, a lot of us, and maybe I'm included in that, when we do research, we do tend to focus, say, on certain types of disease contexts. In my case, it's Alzheimer's disease and related dementias. And a lot of the work, a lot of the focus of treating Alzheimer's disease does tend to focus on people oftentimes when they're in the middle to later stages of the disease. And existing treatments, particularly pharmacological ones, don't show a lot of benefit and efficacy. Part of that is, and we have epidemiologists and others to thank, is when one actually takes into account how can we modify or prevent dementia. It really, in order to do that, we have to see and from a public health lens, what are those factors that can be modified throughout the life course, not just when we're 65 or 75 or 80 or 45. And so when we think of it through that perspective, not just in dementia, but I think in healthy aging in general, it's important to incorporate that life course lifespan perspective. So
Thank you so very much. And if you're just joining us, my guest on this edition is Dr. Joseph Gaugler, a renowned gerontologist. He is here to answer all of your questions, and I know you do have them, and so we'll get to you. But Dr. Gaugler, if you had to identify 3 keys to staying healthy into old age, what would they be? Put another way, what makes the biggest difference in whether someone stays healthy, brain, body, and spirit, or not, into old age?
again, I mean, I think that's the question that we as gerontologists, geriatricians, or others interested in adult development have all been attempting and trying to answer. And again, if it sounds like I'm not answering the question directly, but it is, and I mean, you alluded to it in your question, is it's very much successful aging is multidimensional. It is success, i.e., health socially, it's health psychologically, it's health certainly physically and functionally. So, again, when we talk about healthy aging and what actually predicts whether someone is ages healthy or not, it's a constellation of factors. Many people are very interested when they talk about adult development throughout the lifespan. Many people refer to these biopsychosocial models, it's called, where essentially aging is influenced at the biological level, the psychological level, and then the social level as well. And I think all those three factors interact in very dynamic, complex ways to determine how we as individuals age successfully or not. Yeah. So.
Thank you so much. And which is the reason why we had to talk to you, because
Yeah.
looking at your background, you have the psychology and history as a first degree, and then you moved on to actually taking care of people, addressing the problems of chronic conditions associated with aging. So thank you so much. Now let's bring it into perspective with what we have going on. And when I say that, I mean the unprecedented times that we are in with COVID-19. What are some of the main impacts of COVID-19 that you are seeing on elders' health? And have you noticed a difference between those who are in their homes versus elders in residential facilities or assisted or independent living facilities during COVID?
Yeah, I mean, COVID-19 has been extremely challenging for all of us, but particularly for older persons. I don't think I think everyone pretty much is aware of this, but when one looks at mortality rates in COVID-19, clearly age is a very prominent risk factor, particularly those that are of advanced age, 85 years of age and over. One thing, when I look at COVID-19, I see it in a couple different ways, at least as it pertains to aging. As a gerontologist, I think one thing that COVID-19 has done is it shows how far we have to go in terms of ageist attitudes. Some of the conversations / solutions, you get a sense sometimes there is an undercurrent of ageism in it, particularly if the approaches are along the lines of herd immunity or something like that, where there's almost this underlying belief that, well, look at where most of the mortality and deaths are happening. They're in nursing homes primarily, or primarily amongst older persons. And even though no one will come out and say this directly, you almost get a sense that it's okay as long as we can, get up and running again, or we can get back to the normal life, et cetera. And so much of the discipline of gerontology, as well as geriatrics, has really fought against this attitude of aging as a time of inordinate and unavoidable decline, and being old as stigmatizing. And COVID-19 in some ways really exacerbated what you could argue are underlying ageist tendencies or sympathies, maybe in the U.S. in general. So I mean, that's one impression I have had as a gerontologist during COVID-19. The other thing I think COVID-19 has done, if we can focus, I mean, you asked the question about variations or differences between older people at home versus those who live in residential long-term care. One thing COVID-19 has done is I think it's shown a really harsh light on the inequities of how we deliver and provide and pay for long-term care for older people in the U.S. If you do look at nursing homes or other types of residential long-term care settings, the lack of PPE for staff, many of whom have gone to heroic lengths to care for older people in these communities, the issues of issuing lockdown orders, but maybe not necessarily grasping the impact that would have on older persons, particularly those living with dementia in these communities where, they're suddenly cut off from any type of social interaction, particularly from loved ones. And that has had an effect on their health. I mean, I don't have data to show you from that, but in many of our studies, we've heard from families, and we've been hearing these terms like failure to thrive amongst some older persons living with dementia in nursing homes or assisted living settings. So it's been extremely challenging. But again, one other thing that's I think really important to point out is, these challenges don't just reach to the nursing home for many older persons living in communities. Again, the state lockdown. Again, I'm not arguing against the public health necessity of this. I want to make that really clear. But at the same time, it does have consequences, and one is this issue of social isolation and loneliness. We know social isolation and loneliness is linked to mortality. It is linked to a number of negative health outcomes, particularly amongst older persons. These have consequences, and when you layer on top of that family care for older persons. Again, many community-based services such as adult day programs were also shut down and have been shut down during the pandemic. That also has consequences. And I think, to me, again, getting back to my initial point, the big picture in all of this really is, do we value how we provide care and assistance and services to older people in the U.S.? And sometimes it almost feels as if some of these things are afterthoughts, and they shouldn't be. And so that's been my impression of COVID-19.
I appreciate you, sir. Thank you so much. And this is what you just mentioned. It's quite a conundrum, if you like, or a kind of dilemma. How we're talking about the elderly population being the most vulnerable to COVID. At the same time, you also have what is your thought about supporting the elderly, both at home and the ones that are in residential areas? How do we balance this? Especially when a lot of people have this concern that it is not safe to take them. Also, if you have to take care of them at home, it is not just the best of times. How do we balance this? What do you think? Seniors aging in place at their long-term homes versus moving into residential, the supportive settings with independent living. Should we be encouraging our elders to move?
No, I don't. I mean, again, I think that depends on each individual situation and their care situation, et cetera. In some instances, it is the right decision to move to a residential support setting. In other instances, it's not. I mean, that's a complicated question, I think. In terms of balancing out managing a pandemic versus the needs of older persons in long-term care, some of these are public health solutions. One thing we know, for example, when one looks at COVID-19 rates in nursing homes, the biggest driving factor for whether nursing homes have outbreaks or not is really whether there's been an outbreak in the outlying community. So what that suggests, I think, is, again, in order for COVID-19 or other pandemics to be managed effectively for people living in residential long-term care, the management of COVID-19 at the community level has to be effective, and it has to be robust. And I think many of us would agree that hasn't happened in the U.S. really. I mean, it's been a diverse response and not very effective. And I guess we're reaping the benefits of that, unfortunately. Now, that being said, again, issuing lockdown orders to some community-based programs like adult day services, I wonder if that couldn't be rethought a little bit more in the future. I mean, these services aren't considered essential, and thus were shut down. But in fact, if you ask many family members or older persons who use them, they are indeed essential. And from my understanding, I don't think these programs have necessarily been hotbeds of COVID-19. And so, again, I mean, they could be. I'm not saying they couldn't. But at the same time, maybe if we could ever have a more refined approach, and again, understanding what services are used and are deemed necessary and essential in the context of long-term care would be important, particularly community-based services.
Thank you very much. And could you please explain for the benefit of our viewers, what the difference is between mental health and cognitive or brain health, and how are they related?
Well, I mean, that's a good question. I mean, there are probably certainly psychiatrists that would be able to give a better definition, probably in all likelihood a more accurate one than I. So, mental health conditions, I mean, these are more, you tend to be more psychiatric or psychological in origin. Depression, anxiety. I mean, those types of issues. In many cases, they are linked to neurological concerns. When we talk about cognitive health or brain health, that tends to focus much more on thinking ability, not per se, not so much behavioral abilities in that regard. Now, it is important to know cognitive and brain health, and say something like Alzheimer's disease. You could make a case. In some cases, there's overlap between mental health and cognitive and brain health concerns. Alzheimer's disease, clearly, it's a neurological disorder. However, the symptoms of Alzheimer's disease aren't just functional or cognitive, they sometimes are behavioral as well. And depression and depressive symptomatology is also sometimes an outcome of Alzheimer's disease. So I don't think it's always a clear line between mental health and brain health and cognitive health per se. Oftentimes these issues influence each other in dynamic, complex ways. Maybe that's a theme of our conversation here this evening. I'd love to give straight, simple answers to many of these questions, but in reality, they're not straight or simple. Many of these phenomena operate at multiple interacting levels of influence, making it very exciting and interesting to study, but also, challenging when people are looking for the answer, because there isn't an answer.
I appreciate you, sir. Thank you so much. And something that is related to that question as well. And I also see that we are beginning to have questions from our audience. And thank you very much. If you're just joining us, we are talking about healthy aging. And I have as my guest, Dr. Joseph Gaugler, who is more than qualified to talk about all of that. So, Dr. Gaugler, what is the difference between normal aging, dementia, and Alzheimer's disease? And how common is each of them?
Well, I mean, for Alzheimer's disease and dementia, when we talk about a prevalence, for people over the age of 65, generally roughly 12% or so are thought to have or be at risk for Alzheimer's disease related dementias. That number jumps up to 32% roughly when people are over the age of 85. So age is a risk factor for Alzheimer's disease and dementia, but it's not causal. For a long time, people conflated Alzheimer's disease with being a normal part of aging. As we get older, you'll get Alzheimer's eventually. I mean, some people may have heard the term used, Oldtimer's disease, when referring to Alzheimer's. I mean, that's no longer in vogue. Another term that had been used clinically that no longer is senile dementia. That's another example. Though those aren't used anymore because we now know and understand that although age is a very important risk factor, it's not the only risk factor for Alzheimer's disease and dementia. It's important to know, we all will experience likely declines in cognition as a normal part of aging. I mean, that's normal as we get older. Alzheimer's disease is different in that it is a disease. It's a disease. It's a pathological. It is a chronic disease. And the changes in thinking and memory and behavior that are demonstrable in Alzheimer's disease are very different than normal aging. The Alzheimer's Association, for example, puts out what it's called 10 warning signs, and it's a really wonderful illustration for normal changes that can happen as we get older in cognition, thinking, and memory versus the changes in those domains that happen with Alzheimer's disease, which by and large impact our ability to engage and carry out everyday activities. I mean, that's probably the best way to think about how Alzheimer's disease is different from normal changes in it with aging.
All right. So I will come back to the question about why Alzheimer's, but we have Joseph, who is a member of our audience, that is asking, are you optimistic about the COVID vaccine in the elderly population, Dr. Gogler?
Yeah, I'm optimistic. I mean, I think if one is to believe what we're hearing from media reports, and I think we can, is certainly older persons and will be particularly those living in residential long-term care will be early recipients of the vaccine, which is good to know. And one has hope that enough doses will be available to cover those individuals as well as their care providers, which I think is really important. The direct care staff in these settings are vaccinated appropriately. So in that regard, I'm optimistic. But again, I think we have to step back for a second. So COVID-19 hopefully will dissipate, sometime soon. But what has that really showed us about, again, how long-term care is paid for, regulated, and delivered in the U.S.? I mean, it's been an enormous challenge for long-term care, and it should really make us think carefully about a reset and why a reset is needed. Again, and how we fund and support these settings, how these settings are regulated, so that when they are regulated, they are being regulated according to issues and concerns that are of most importance to the people living there, as well as their families and care staff too. Um, and also thinking about environmentally, are these the right kinds of places that can allow for healthy aging? Um, Many times the physical spaces of these nursing homes are not by any means ideal. And we do know smaller home kind of settings, even for older persons with significant health needs, can be beneficial for them. So again, there are a number of different areas where COVID-19 has really demonstrated the need for us to rethink long-term care and reshape it. The Robert Bob Kane, who who my endowed chair is named after, someone who was my mentor and a colleague for many years until his untimely passing in 2017. This was an issue that was near and dear to his entire scientific persona, rethinking long-term care, re-envisioning it. And I always kind of wonder what he would think if he saw COVID-19. I have a feeling he probably thinks similar as I, in that COVID-19 was a devastating event, but it basically exacerbated the problems and issues that have been apparent in residential long-term care for a long time.
Thank you so much. And we have another question from Judy. Judy's asking, do you think Lyme's disease has a dementia component?
Yeah, that's a good question, Judy. Not to my knowledge. To my knowledge, Lyme's disease is not a risk factor or predictor of Alzheimer's disease and dementia. I'm not as familiar with Lyme's disease per se. I mean, it may very well have certain cognitive components. It may impair cognitive function. Again, I'm sorry, I can't answer that per se. But as far as it having links to Alzheimer's or dementia, I haven't read or seen anything about that. One thing I will make a point, I think it's important to point out is, and again, Dr. Kane always said this, and it's something I like to repeat, is absence of evidence doesn't mean evidence of absence. There's still much we need to know and learn about potential risk factors for Alzheimer's disease that simply haven't been studied. That doesn't mean that those links aren't there. They're just waiting to be discovered. So always, when I say and I list risk factors, always take it with a grain of salt, because in all likelihood, there's probably many other factors that we just don't know about.
Thank you so very much. And that leads me to my next question. Why do we hear so much about Alzheimer's now? I mean, is it like was there no attention given to it, or is it that we're learning so much new stuff about it? For example, people are asking the question, before now, we only heard about dementia, but now we hear so much about Alzheimer's. Is it truly more common than in the past now, or is it there just more attention and diagnosis of it?
Yeah, I mean, so Alzheimer's disease was first diagnosed in the early 20th century, around 1906, and it was named after Dr. Aloy Alzheimer in 1910. So it's clearly been around for a long time. I think part of the reason why Alzheimer's disease has become seen and viewed much more as a public health concern is in part the aging of the population. And as I noted earlier, one of the most consistent risk factors for Alzheimer's disease, although it's not a normal part of aging, is age. And with the largest number of older persons that we've ever seen, really in human history, the number of people living with dementia is much greater than ever before. And with that has come, calls and basically different healthcare entities and such. They're starting to identify and see that, this is a problem. This is, from their perspective, it's a problem. It's an issue. What are we going to do about it? How are we going to care for this many people living with dementia? That's why I think it's becoming more and more, or it has entered more and more into the public consciousness to date. So
thank you very much. And of course, if you're just joining us, we are talking about healthy aging with Dr. Joseph Gaugler, who is my guest on this edition of the program. And do not forget that I did mention that you're going to have the opportunity to win a gift card. So stick around with us. Do not forget it. And we're going to have that very soon. And you know, the topic we're discussing today is very important, not just for people who are older, but people who are taking care of elderly ones. Simply put, let me put it this way. If you have anybody in your family that, their birthdays have come up, and of course, when you are no longer buying that many candles, you just buy one candle. You know that you're gradually transitioning to that stage, okay? When you have too many candles, you can't have 65, 70 candles on a cake. There would not be cake anymore, just be a collection of candles. So when you have one candle, you know that something is happening. So the next thing I want to ask you, Dr. Gogler, is this. A lot of times, how do you recommend intervening with a family member who you think has dementia? How do you facilitate or ensure an exam or assessment, especially if they will be defensive?
Yeah.
And what is the value of making sure that they get an assessment?
I mean,
because a lot of times people don't even agree.
No, I think that's a really good question. It's a very challenging situation when someone who a loved one likely has memory concerns or issues. There is a stigmatization with memory loss and dementia, and people don't want to be labeled with that. And so there's often a lot of pushback and resistance on the part of our loved ones who don't want to go through that process. Generally, I think as family members, it's really hard. I've had this experience with my dad, who passed away a couple of years ago. I'm sure many of you have too, where, coming from family members, requesting, asking, maybe even nagging or being more forceful isn't always the most effective approach to having someone really agree to a memory assessment of some kind. Probably the best strategy is to work with a trusted third-party professional that this person, your loved one, respects, that could maybe help them start to understand and think why this might be important. I mean, the most logical choice is, if the loved one has a good relationship with them, is the primary care provider, is figuring out a way where the primary care provider could begin to bring up the issue of brain health. Not talking about dementia or Alzheimer's, but brain health. And, primary care providers are reimbursed for doing this, where they can simply administer a very short assessment, a valid one, determining whether there's probable dementia or not. And that might be a good first step and a way to kind of get the ball rolling. And if there is an underlying problem, using, again, hopefully a positive relationship with the primary care provider to then initiate a referral to a specialist. I have one thing I want to say here, Victor. I think this is important.
Okay, so go ahead, please.
Kind of following the private chat here and everything. And, there's been some comments about, needing a positive, uplifting story, nothing related to this issue or anything like that. The implicit assumption is aging, and what we've been talking about up to this point, and this is kind of based on the questions, has been more focused on aging as decline, aging as, disease focused and all of those things. And, one way to really flip that around and think about this in a more positive way is, again, the fact that there are more older people now than in all of human history isn't a problem. Some people call it the aging tsunami, and, what are we going to do? How are we going to deal with this? The flip side of this, to look at this, is a major, unprecedented public health achievement that this many people have been able to live this long, most very well to this point. And that's something we shouldn't forget. And when we talk about Alzheimer's, we talk about dementia. Again, oftentimes we think of it in a biomedical lens. It's a disease, it's decline, behaviors, negative, et cetera, et cetera. But there really is a growing, burgeoning movement, and this is amongst people living with dementia themselves, as well as their family caregivers and other advocates, of really forcing us to rethink, number one, how we talk about and think about people living with dementia. You notice I use the term living with dementia. I'm not saying someone suffering with dementia or a patient or anything. People who are living with dementia are still living. They still have preferences. Oftentimes they still have voice. And when we think about how we care for people living with dementia, it's really important for us to remember that instead of focusing inordinately on the decline, the negative aspects, we should also be focusing on what people living with dementia still can do and orienting our care strategies, our approaches, our policies around that. That's why, when we think of healthy aging, it's important to think about that perspective. Almost you call it resilience, a strengths-based perspective, successful aging, whatever you decide to call it. But approaching it that way, both for ourselves, but then also for those around us. I think that's really, really important because again, as gerontologists, geriatricians, the whole point of our discipline is to fight against what was the predominant idea that aging is a disease, aging is decline, aging is hopeless. It's not. And our research has shown that. So I really want people to remember that.
I appreciate you. And of course, we were just talking before we got on that life expectancy has actually risen. In 2017, a report came out that from 68 to 78. So if you have a problem with aging, you are going to have more problems with aging because we're not going anywhere. Like Dr. Gogler said, we're going to have a lot of people transitioning into that phase, and we have to embrace it, and we have to do so in a healthy way. Now, I just wanted to mention that, well, 1 second, I think I needed to get this up. What are the pros and cons of living in an urban area or in a rural area, especially as it relates to aging? How does that affect anything, Dr. Gogler?
It's rural versus urban. It's an important variable. It's an important issue to consider. Again, it's not the only one. Again, a running theme of our entire conversation here is social context or geographical context is important, but it's one amongst many other factors that can influence how we age. Now, that being said, depending on where you live, rural is big. Rural means a lot of different things. There's a lot of places classified as rural that are very, very different in terms of whether, for example, they're age friendly or not. I'm using the term age friendly. Some places, if there are needs for services and one lives in a rural area, they could be geographically dispersed in a way that makes it very hard to access needed services, whether it's primary care, specialty care, etc. The flip side of that is that potentially, and again, this depends. Rural America is changing as much as urban America, but in rural America, there may be certain types of community connections that are more easily facilitated and maintained than they are in urban areas. One example is sometimes when I visit nursing homes or other residential care settings in these rural areas, one of the things that strikes me is a lot of the times the direct care staff in these places, they know the people they're caring for personally, or they know their families, they've grown up with them, etc. And that to me is an upside, a potential benefit of a rural community, maybe versus an urban community where you don't have those types of connections.
Thank you so very much, Dr. Gogler. I really have so many questions to ask you, but let's talk about the University of Minnesota School of Public Health Center for Healthy Aging and Innovation that you now lead. What is it, and why is it important for us to know about it?
Yeah, the Center of Healthy Aging and Innovation, it's a redesign of what was called the Center on Aging. The Center on Aging existed. It was founded and directed by Dr. Bob Kane from 1994 until his passing in 2017. When I assumed the Robert L. Kane Endowed Chair in the School of Public Health in 2018, one of my main goals was to redesign and relaunch the Center on Aging as one that is community-facing, one that is responsive to the needs of Minnesotans and other persons beyond, and then also is welcoming and encouraging to all faculty, students, and staff interested in aging at the University of Minnesota. The center itself, its guiding principles are one, approaching aging in a multidisciplinary way, being, again, responsive and interactive with our many external stakeholders, and to advance aging science, scholarship, and practice at the university as a whole. We have a very, we've already been engaging in, and we will continue to build. We just relaunched this fall, but we already have a core of research activities, an educational core where we're redesigning and rethinking different educational programs in aging. And then we also have an equity and community engagement core, which will be the main vehicle for, again, working with and partnering and collaborating with our external stakeholders. So that's the Center for Healthy Aging and Innovation, or CHI. We are convening our first assembly of all of the members and community partners actually next week, and we're very excited about where we go from here.
Thank you so very much, Dr. Gogler. My guest has been Dr. Joseph Gaugler, renowned gerontologist. Of course, he has shed a lot of light on so many topics that we unfortunately cannot cover it all, but we want to thank you, sir, for coming on the program today.
Wonderful. Thank you, Victor. I really appreciate it. And thank you, everyone, for your time today. Great questions, and I hope it was helpful.
All right. And at 10,000 Families, we are inviting families to participate in our study and looking at genetics, lifestyle, and environmental influences on individuals and families' health. What do you think are the opportunities of a multi-generational family study for improving our knowledge of healthy aging? These are all of the things that inform what we are doing with this virtual series. So join us again, because we will be having another edition of this interview that would be on February 10 by 4:30 p.m. And the focus would be on health disparities. Do not forget, February 10th, 4:30 p.m. is going to be live on this broadcast. And also, I have been reliably informed that we have a winner for the gift card today, who is a namesake with our guest. That is quite a coincidence, Joseph Lawden. Thank you very much, Joseph Lawden. Our team will get in touch with you. It has been a pleasure to have this conversation. And until we come your way on February 10th, thank you very much. My name is Victor. Bye-bye.